Hi and welcome. Thank you so much for attending today. We are going to share a bit about the Medicare Shared Savings Program and the mechanisms in which it operates and which it can be successful. We're also going to share information about how you can join an ACO for 2025 and your options, and present an opportunity to join a Texas-based rural health clinic specific ACO with Value Health Innovations. So first I'll go over who are we? What's Value Health Innovations? We have 22 years experience in value-based care, 10 years experience in operating ACOs, Medicare Shared Saving Programs, and CINs. And we'll talk a little bit more about those acronyms as we get through it. We are here dedicated, supported to rural communities. We all come from rural communities and are raising our families in these communities, and we want to see the support of the healthcare systems in rural healthcare. Alternative payment model continuum really looks at how do we transform from fee-for-service to models that incorporate quality of care, reduce cost, and improve patient satisfaction, as well as provider satisfaction. These models have come around due to the fact that we continue as a country spending more and more in healthcare dollars in this fee-for-service framework. So alternative payment models have been tested over the last 15 years and exist across the continuum. The first piece here is pay for performance. Usually this is a quality outcome infrastructure payment that incentivizes better quality performance. So there's no risk. It sits on top of your fee-for-service structure. You still get paid fee-for-service. And then in addition, if you perform well in quality metrics, you get additional bonuses. Then if you move over, you start to look at cost in addition to quality and patient satisfaction. These models are like a shared savings program that can be at no risk or at risk. So meaning if you don't achieve your goals, then there could be risks to paying back the payer. And then finally, moving over to really bundles and capitation. This is a set payment for a population, and it's taking on the full accountability and risk for the population, and it really gets to that full model of an alternative payment model that's not built on top of a fee-for-service model. So as you go across the continuum, the execution and risk increased, and the infrastructure you need increases. Today, in healthcare in 2022, looking at the all payer data, 40% of transactions were made strictly fee-for-service, while 60% had some sort of alternative payment model structure. So you can see that we have really grown into these alternative payment models as a nation. And today we are going to discuss more what a shared savings looks like under Medicare Shared Savings Program. So how do you structure a Medicare Shared Savings Program? You have an ACO, which is an accountable care organization. This is the entity that contracts with multiple different provider groups. With an ACO, you participate at a tax ID level. So if you have a practice that has 5 practitioners in it, then you would sign up your tax ID and all 5 practitioners are part of that ACO. It's not a pick and choose by provider. So the ACO is that entity that contracts with the provider groups. Then the ACO contracts directly with CMS under the Medicare Shared Savings Program. The ACO is led by a clinician governing board. This is a requirement, a compliance requirement under the Medicare Shared Savings Program. So a governing board is usually made up of the participants. Those providers, part of those tax IDs, help lead the ACO activities. As part of the Medicare Shared Savings Program, the patient population that's being measured is based upon the patients that are being seen by those providers in the ACO. So looking at a Medicare shared savings program, it's specific to traditional or original Medicare patients. So not Medicare Advantage, only traditional Medicare patients. And it could be your enrollment types of ESRD, disabled, dual, or non-dual patients. Patients are assigned to the ACO based on the plurality of care with the PCPs. To participate in the Medicare Shared Savings Program, you must meet a minimum of 5,000 patients. So altogether, all the participants must have at least 5,000 patients assigned to the ACO to be able to participate in the Medicare Shared Savings Program. Now, a CIN, a clinically integrated network, looks a little different. A CIN contracts with different payers outside of traditional Medicare. So a CIN might contract with Medicaid, commercial, Medicare Advantage, whereas an ACO structure is specific to a Medicare population. So you can contract actually with those two different types of entity. You can have a contract with a clinically integrated network, and then you can have a contract with the ACO. ACOs are exclusive, so you can only participate in one ACO. Let's talk about how the financial mechanism works in level A and B. And I'll explain the levels later on, but really this is the very first step to the Medicare Shared Savings Program of where you can start. So they look at your patient population as part of your ACO and the historical expenditures of that population. So how much did that population cost in the past 3 years prior to your participation? And they come up with a benchmark expenditure for that population based on historical costs, based on trended regional and national adjustments, as well as the risk score of the population. And we'll talk more about the risk score later on in the presentation. So you get the set benchmark. And then as part of the Medicare Shared Savings Program, you're looking to reduce cost of care and increase quality. So you want to come below that benchmark. In the program, CMS sets a corridor in which it's a percentage below your benchmark that it says, oh, you have some savings, but not enough to be significant for full shared savings. So typically your corridor is around 3%. So if you come in, let's say at 2.5%, your expenditures for the year are 2.5% less than your benchmark, then you get a small portion of that savings, 20%, and CMS retains the 80%. Now, if you share savings below the 3%, so if you share savings, let's say at a 6%, so your population spends 6% less than the benchmark, then this is when it activates the shared savings. Shared savings means that total amount that was shared, or that total amount that was saved, is then shared with the ACO. So CMS, as you begin in level A and B, will share 40% of that savings and retain 60%. And as you move along the glide path of the levels, you can receive more shared savings. In level A, there is no risk. So if you go over your benchmark, you do not owe CMS. So that's what no risk is referring to. They set a target goal, and if you come below and get shared savings, great. If you go above, then no harm. So this glide path that I had mentioned goes from level A to enhanced track. And as you move along the continuum of the path, you can receive more shared savings, but then there's also more risk. So level C is the first entry level to risk. An ACO can start in level A or B, or it can choose to go ahead and go straight to risk. And as you have in your contract, you can choose to move. You can always choose to move up levels, but you cannot move down once you get to a certain level. The agreement period between ACO and CMS is a 5-year agreement period. The performance period is on an annual calendar basis. So they'll look at your performance every single year, and determine if you received shared savings. And then your contract with CMS remains for 5 years, and then you can renew it if you want to continue to participate in the Medicare Shared Savings Program. As you do move to risk, there become some benefits in participating in risk, for example, like the SNF 3-day waiver. But in no risk models, there's not those additional programmatic benefits. Now, as we talk about participation in a Medicare Shared Savings Program and an ACO, it's really a stair-step journey to success. You aren't building this full infrastructure at the beginning. You're continuously improving on it and building it as you go throughout your 5-year contract agreement. If you're a brand new ACO and no historical participation in a Medicare Shared Savings, you get to be in level A for 5 years. So you have no risk for 5 years, and that gives you the opportunity to build these structures. So some of the first things that you really go through is contracting, making sure that the ACO contracts the provider, participants, knowledge share, learning about the ACO, learning about value-based care, and really helping to start that culture change shift. That doesn't happen overnight, but you begin those discussions. And then the next 3 are the items that you work on typically first as an ACO. So risk score capture, wellness visits, and quality measurement. I'll expand on those a little bit more. As you go up this ladder, you create more infrastructure around data, care team support, and patient engagement. So let's dive into kind of the levers that you can look to perform better and be successful in an ACO. And perhaps you're part of an ACO today and you're not sure how that's really connecting to your overall success. I wanted to share how the initiatives really connect to your financial performance. So first, we're going to look at the benchmark expenditure for the population and understanding some of the dynamics and levers in which determine your benchmark. The benchmark is a 3-year historical calculation of the population expenditures and risk. So it looks back at those expenditures and the risk of that population. The risk score predicts the individual members or the individual patient's expenditures relative to the average member. So it's looking at what does an average Medicare beneficiary spend in healthcare cost on an annual basis, and then how does that individual that's assigned to your ACO differ in their risk score. And the way they capture this is through diagnosis coding. The annual wellness visit helps with the benchmark as well in terms of patient assignment and attribution. You have to continually see your patients on an annual basis at least so that you can maintain that patient population as part of your ACO, because remember, they're assigned to your ACO based on their plurality of PCP care. It also gives you an opportunity to address quality measures and ICD-10 codes. Attribution. The method in which patients are assigned can be whether it's physicians, NPs, or PAs. This is that assignment methodology, and it is critical to your benchmark so that you maintain your patient population. In addition, there's different ways in which attribution happens, whether it's retrospective, prospective, or patient voluntary elects their PCP. Retrospective looks at the end of the performance year, the patients that saw your PCP for that performance year. Whereas prospective looks at the patient population that saw the year prior to the performance year and assigns those patients to your ACO, and that list does not fluctuate as much. Risk score capture. Risk score capture. A little bit more detail into this. Risk score capture is, remember, that risk of your population compared to the average Medicare population. It starts over every calendar year. So a patient's health risk is calculated on a calendar year and can be different year to year. it's important to code annually most appropriate and specific diagnosis for a patient for all their chronic diseases. So if you're coding a diabetes without complication versus a diabetes with complication, that can have a different risk associated with it. Documentation must support the coding. So you must have that meat in the documentation to support your diagnosis coding. And then a risk score capture, a risk score is on a scale of 1.00. So anything below a 1.00, which one is a average risk of Medicare beneficiary, anything lower than that represents a healthier population. So if you have a risk score of 0.90, that means your patient is 10% less likely to spend on medical expenses for the year than the average beneficiary. Whereas if you have a patient population that has a risk score above a 1, it represents a sicker population, meaning that they'll spend more. So then let's jump to the shared savings piece and quality. So your shared savings will be adjusted based on your quality performance. In the MSSP, there are different ways you can report quality. The manual chart review reporting, which is 10 measures, is sunsetting. So going on a go-forward basis, the annual reporting will be based on electronic reporting. These are capture 3 measures that must be captured for the whole population, not just your ACO population, and include diabetes, A1C control, screening for depression, and controlling high blood pressure. The other 2 measures of 30-day readmission and a risk standardized hospital admission rates, those are claims-based. So the ACO doesn't have to report those. They're just calculated based on claims. And then lastly, we CAPS for MIPS, which is CAPS for the ACO. This is patient satisfaction. So the ACO will conduct a patient satisfaction reporting. Cost and utilization management. Across the continuum here, your cost and utilization management should start out pretty basic with gaps in care outreach. And then as you grow as an ACO, you can start to expand your care management team. Now, some ACOs will operate the care management team for you at a centralized hub, which provides efficiencies, less resources. And then some ACOs require the participants to do the work and the outreach and hire the care management team. So gap in care outreach helps outreach to patients to get them into the clinic for their wellness visit, for quality gap closure, for preventive care. Transition care management is another step up that works to help coordinate that transition from inpatient back to home or from the ER back to home. So this is transitional care management, post-discharge, post-ER visit, helping reduce readmissions and reduce preventable and avoidable ER utilization. Then you grow into longitudinal care management. This really means management across the continuum. It contains complex care management. You're working to close social determinants of health gaps. You're looking at your post-acute care network to make sure that they're going to the highest quality post-acute care facilities. You can incorporate remote patient monitoring, and then also network integrity, making sure that they're going to the right providers that align with your goals, and increasing quality and reducing care. So all this, put in all the work, and you have shared savings. Woohoo! As an ACO, that's the ultimate goal. Once you put in the quality, and the ultimate goal is to serve the patient and provide better care. But a part of the program, you also want to have that funding so you can continue to provide excellent care to your patients. So for shared savings, the performance period again is on a calendar year. So for example, 2025 would be calendar year performance. The ACOs don't receive their results until August of 2026. So 8 to 9 months later. And then the shared savings actually comes in 9 to 10 months later in September to October 2026. So there historically hasn't been a lot of funding up front. You don't receive your savings until after the performance year. If you get the savings, and when you get the savings, the CMS will pay those savings to the accountable care organization. And then the ACO will distribute those savings based on the ACO's funds flow policy. Typically, the ACOs will put a portion to their infrastructure, and then the rest will go to participants. The ACO's funds flow policy is determined usually by the board. And so if you look at joining an ACO, that should be one of your questions that you're asking. What is your ACO funds flow policy? Some ACOs might retain all the savings to cover infrastructure first, and then anything left over goes to participants. And then if you have an ACO that has a network makeup of hospitals and specialists, they might be receiving some of the shared savings as well. So it's really key to understand the network as well as their funds flow policy when you're considering joining a shared savings program. This kind of alludes to what I was saying, that all ACOs are not created equal. So you have hospital-based ACOs. These are ACOs that are supported by the hospitals and systems. So the infrastructure of the ACO is all covered by the hospital. Usually when you get shared savings, the hospital has a role in determining how those savings are distributed, and usually the hospitals will receive part of that savings, plus the participants, plus helping with the infrastructure. You have independent ACOs that are formed with a network of only clinicians and no hospitals. And this is the type of ACO that Valley Health Innovations is creating. Independent ACOs historically have performed better in the Medicare Shared Savings Program because they can look at all across the continuum to look at cost saving measures and processes. And then you have big corporations that operate ACOs as well, that bring together multiple different populations. So it's a very large patient population in the Medicare Shared Savings Program. And these look like CVS Accountable Care, could be like a Main Street, groups like those. So participation again is exclusive, so you can only participate in one ACO. If we look at the history of Medicare Shared Savings Program, it continues to grow. There was a plateau in kind of that 2019 to 2023. So CMS has created additional incentives to growth that I'll talk about here in a minute. But if you look at 2024, there's 480 ACOs. So definitely it grew from 2023 to 2024. Their goal is to have all traditional Medicare patients in some sort of alternative payment model by 2030. So in 6 years, that is their goal. New ACOs, like I talked about earlier, that have no history of participation in an ACO can be at no risk for 5 years for the first agreement period. And then in their second renewal agreement period can do additional 2 years of no risk. So as a new ACO, you can avoid risk for up to 7 years. Also, from 23 to 2024, there was a 27% increase in the rural participation in Medicare Shared Savings Program. As of 2024, there was about 9,000 FQHCs, RHCs, and critical access hospitals now participating in ACO. And then you can see there also that the light blue is your downside risk and dark blue is upside risk. So downside risk means that there's no risk at all, and upside risk meaning that there is financial risk. So it's going to be any of the levels above B. So really, CMS looked at this and said, hey, we want everyone to be, all Medicare beneficiaries to be in a alternative payment model. How do we make that happen by 2030? They want to drive accountable care. So they're starting to put in mechanisms that incentivize new participation. They also, in their strategy, called out advanced health equity, supporting innovation, addressing affordability, and achieving system transformation. So in this new phase of accountability, there has been new models in terms of the Medicare Shared Savings Program and Medicare beneficiaries. The Medicare Shared Savings Program is a legislative program. So it's governed by regulatory statutes and updates. Every year, there's updates that will come out that adjust some of the program dynamics. And for example, in 2024, it was the first year they introduced advanced investment payments. The ACO REACH model is not a legislative model. It ends in 2026. It's part of the Innovation Center testing. So the thought is, let's test this new model. If there's pieces that work, then we either put a new legislative model in place or we build that into the already existing Medicare Shared Savings Program. This model is capitation and is a risk model. The newest model that was announced this year is the ACO Primary Care Flex model. This is part of the Medicare Shared Savings Program. So if you are part of an ACO, this provides an opportunity for prospective payments and increased funding for primary care. Let's talk about the advanced investment payments. I think this is key for you to understand while you're considering joining an ACO, so that you would know, is this ACO applying for these advanced investment payments? And is that information being shared with us? Are we eligible to receive some of those payments? And how is the ACO going to use those funds to support the success? So an AIP is something new in 2024 that provides 2 years of startup funding. You get a one-time $250,000 upfront payment as an ACO, and then you get 8 quarterly payments based on the number of assigned beneficiaries. So typically the $250,000 is put into infrastructure, and then the 8 quarterly payments can be shared with its participants to create funding in the clinic space for care team models. There are specific qualifications that you have to be new to the MSSP. You cannot include a hospital in your network, and you must not be owned or operated by a health plan. The AIP details there, you can see on the side. This advanced investment payment is at no risk as long as the ACO remains in the MSSP program for 5 years. So if you do not receive shared savings in the first 5 years, you do not have to pay these funds back. However, if you do receive shared savings, then these funds are deducted from those savings because they're seeing this as an upfront shared savings payment. So you'll get the remainder once your AIP is deducted. Another key point in the funds flow mechanism, if your shared savings percentages go on to the participants, then you would expect that a percentage of your AIP should go to your participants as well. So the Value Health Innovations ACO, this is an ACO that is going to be new for 2025 that will be eligible for the advanced investment payments. It's a shared governance model specific to Texas-based independently owned rural health clinics. In this structure, your providers will have the opportunity to join the board to help direct initiatives and strategies and policies. In the advanced payment option, as we apply and we get certified to receive those fundings, we will distribute a per member per month payment starting in 2025 to participants that participate in the ACO. And again, this is a new ACO, so there's no risk for 7 years. So it's a great opportunity to build the structure to be successful in the future. In addition, we'd like to start coordinating activities now. Again, your benchmark is the 3 years prior to your performance year. So if you start in 2025, 2024 is part of your benchmark year. So it's really key to start addressing risk score capture, because that risk of the population helps determine where your benchmark is going to be set. And if you have a higher risk population, then you're going to have a higher benchmark of medical expenditures for your population. And then we will take on all the administrative burdens and functions of operating an ACO, and look forward to working with you all if you choose to join. Selecting ACO participants, our goal is really to have a rural-focused provider network of RHCs. We will look at strategic discussions on the criteria of participation and the selection of the board. And again, just a reminder that we will not include hospitals. We aren't owned by a health plan. We are Texas-based and have been doing this for over a decade. The application period for 2025, so to start at MSSP January 1st of 2025, CMS released the application dates in February. Essentially, the application opens May 20th, and your first participant contracts are uploaded by June 17th. The last day in which we can upload participants and add them to our ACO is August 1st. And then we go through a round of governance structure and additional information in the application in October. And by December 5th, we have our final approval for an ACO. So looking at that timeline and what that means, today we're in April, and so we're delivering the message of what is an MSSP, and we'll continue to deliver that message through the next 3 months. We hope to have executed agreements, our first round, by June, so that we can apply for the ACO. And then by July, we'll have any additional participants and those executed agreements completed. And then August, we'll select our ACO board and then start working on education of what an ACO is and look at risk score capture mechanisms, as well as setting up quality reporting. CMS will release our first ACO beneficiary list in December, so we'll know who those patients are in December. So this business model that we're proposing for Value Health Innovations, which we have an acronym, of course, VHI, is RHCs will continue to receive their regular Medicare payment. And then when we get the advanced investment payments, we plan to pass through a percentage of those dollars under a per member per month payment starting in January. And then you'll receive additional guidance from us. We'll be there hand in hand, help supporting you. We realize that rural healthcare can have its nuances and be very short-staffed or short-resourced, and we're here to help in these initiatives and not just share best practices, but be there alongside you to help you through the challenges and barriers of implementation. For the first year and in preparation of joining an ACO, these are the expectations that we would have in a collaborative manner. You have to do beneficiary notification and putting a one-page sheet in your office saying, hey, you are part of an ACO. We want to work on ICD-10 coding so that we're capturing the risk of the patient population accurately. Also, wellness visits, making sure that all your patients are getting assigned to the ACO. And by doing wellness visits, that helps assign the patient to the ACO. And then quality measure performance, looking at those 3 quality measures and optimizing performance, as well as reporting electronically. So in summary, we have years of experience that we can offer to the rural community. We are independently based. We're not a big corporation, so we're nimble and flexible in our initiatives and how we can roll out the program. We look forward to working with our rural communities. If you have any questions, feel free to outreach to me. Happy to set up some one-on-one meetings as well. And if you aren't choosing VHI-ACO, I'm happy to help you in other ways to look at the ACOs you do want to consider and provide questions you should be asking, considerations, and just being more of a consultant as you navigate the decisions. If you have any questions, please take a moment now to ask those questions. Okay, well, I don't think we have any questions. Great. We'll share the slides after this as well as the recording. Thank you so much for your time today, and I look forward to working with y'all. Bye.